talk will have a little bit of a different approach. So let's forget about titles and about topics and start with a brief case presentation. Okay? According to which we will discuss some of the drugs in the table. Okay. Here's a case. It's a real case, but a little bit modified and shortened. So please focus, and we'll have a discussion afterwards. Khalil. It's a generic name. He's a 35 years old man. He came to the ER complaining of sudden fainting while playing football. Okay? His friends, as you can see here, reported, what's that? They reported that he lost consciousness for about 2 minutes, during which he had no convulsive or spastic movements. And afterwards he was able to walk and he was conversing. Right? In the ER, we completed the history and we found that his family history was unrevealing, which means there was nothing positive. His past medical history was negative. His social history, he's an office worker, he is single, he's non-smoker, and now alcoholic. He reported no medications or allergies. During the physical exam, his vital signs were the following. Heart rate was 92 beats per minute, and it was on a regular rhythm. The respiratory rate was 16 breaths per minute. The blood pressure was 125/65 millimeter mercury, and the temperature was 36.7. The auto-sat was 97% on ambient air. The lung fields were clear, and the heart sounds were normally split S1 and S2. It was on a regular rate and rhythm, and there were no murmurs. And finally, the neurological exam was normal. Okay. Before we get into the differential diagnosis, anyone has any further questions, whether in the history or in the physical exam? It's a brief history exam.
What does normal S1, S2 mean?
You haven't studied that in the physiology of the heart? Okay, it's the normal sounds of the heart, S1 and S2. You should study that, I guess. Okay, any further questions? Whenever you hear the blood pressure you see here, you have to always ask about the differences between the postural and supine blood pressure. Okay? Particularly in this patient complaining of something we call syncope. Right? So, are you interested in that? There was no difference between the postural and the supine position of blood pressure. Okay. What do you think? Give me 3 basic differential diagnoses for this case. Just think. Someone has nothing, absolutely nothing, and he fainted and fell on the ground, lost consciousness for about 2 minutes. By the way, my exam questions will be like these. They're going to be cases. So please focus. Go on. Say it again. Good. You have a problem? Good. Again, it's a differential diagnosis, so there is always pros and cons for each one. Okay, so let's say she had something related to the heart. There's a problem in the heart. What else? Go on. Good. That's great. Hypoglycemia. But will he lose consciousness? Maybe not. So, pros and cons. What else? Hypertension, exactly. You hear of something called the vasovagal syncope. Someone who's just normal and had a bad day or something like that, and he had this reflex, and they just lose consciousness or had syncope. Go on. Yes, as we said, vasovagal syncope. You know what's the meaning of syncope, by the way? Okay, syncope is a symptom. The patient just faints, okay, and they might lose consciousness. There's something else called near syncope, okay? Again, the patient complains of lightheadedness, all right? Maybe some numbness and dizziness in his peripheries, and then he might have some sort of fainting. Take it as for granted. Whenever you hear syncope or near syncope, it's an alarming sign for something going on in the cardiovascular system. One of the major differential diagnoses for syncope is cardiovascular problem. All right? So let's keep it going. Maybe, that's good. Could be stroke. But again, he's 35 years old. He had no medical history and no family history, but it's good differential diagnosis. You have a question? Or? Okay. Sorry. Might be. Okay. Well, let's keep it there. All right. So we have some things, let's say, related to the heart, and I would say, and I suggest, that it could be a cardiac arrhythmia, particularly this age group, 35 years old. Always keep in mind that they might have cardiac arrhythmia. All right. So that's our topic today. It's cardiac arrhythmia. And before we get to the meat of the topic, let's just go over some basic knowledge. And this basic knowledge is particularly important to understand the antiarrhythmic agents. Let me say this. Antiarrhythmic agents, it could be a very hard topic, but at the same time it could be a very easy topic, depending on the approach you take with studying them. So please focus on what I will say in the introduction, because it's going to be helpful for you to understand what's going to happen next. All right, so we will go to the very basic. This is the heart, and we have the SA node representing the pacemaker. These are things we discussed previously, and it relays and converts the signal into the AV node, which then conveys the signal into the electrical conduction system represented by the bundle of His, the left and right bundle branches, and the Purkinje fibers. You have studied these in the anatomy. As we said previously, the SA node represents the pacemaker, and it sends like waves of signals into both the left atrium and then goes into the AV node. The AV node's major function is delay, right? To give the atria enough time to empty their full blood content into the ventricles. Now afterwards, the signal will be transmitted through these electrical conduction fibers and spreads into the ventricles to produce the contraction. Okay? All right. But the thing is, how does that happen? And the question is, how do cells interact with each other? With each other? And how do they leave messages from one side to another? And the answer to this question is simple. It's all about setting the membrane potential of the cardiac cells. All right? So, how do we set the membrane potential? And let me start with showing you the old famous line, which is the membrane potential in millivolts, okay? And that's going to be plotted versus time in milliseconds. Now, let's say here's a cardiac cell, and it starts always somewhere in the negative, between minus 70 and minus 90, let's say, okay? And you know this is something called the resting membrane potential, right? And you should also know how is that generated. how do we generate the resting membrane potential? One. Sodium, potassium, and pH. Okay? It's responsible for that. We will see it in a minute. But let's say it was minus 90 and all of a sudden it reached minus 60. This minus 60 in most of the cardiac cells is considered as the threshold, after which the action potential could be generated spontaneously and the cells will go into a state of depolarization, which means reverting the resting membrane potential from the negative into the positive. Okay? Now, it continues for some time, but all of a sudden, it starts going down. This going down is not very smooth. It does not go down as fast as it went up, right? Actually, after this minor going down, it starts in a phase of plateau, right? This plateau represents something called the sustained cardiac contraction or ventricular contraction, right? And finally, the cell starts going down, or the membrane potential starts going down in a phase which is called repolarization. And then goes and repeats the cycle. All of these things are basics, right? You know these things. Now, but let's say, here's a key for you. Anything that goes up is called depolarization, and anything that goes down is called repolarization. Good? All right. Now, that's simple. But the thing is, how does that happen? What's responsible for each of these stages? And we will start with this one, which is the sudden upstroke. Upstroke meaning going just high all of a sudden and in a very sharp and steep manner. Now, this phase is called phase 0 of the action potential. Now, how does that happen? How does the cell change from being in a negative membrane potential into suddenly going up into plus maybe 30 or 40 millivolts? What's the action? Just think about it. What? Say it again. Fast sodium channel. Okay. So the basic thing is just getting something positive inside. Because the resting membrane potential happens by the fact that we are exchanging 3 sodiums, which are positive, in exchange of 2 potassiums, which generates something of like a relative negativity of the membrane potential. So to switch that into a more positive manner, you just need to get positive ions back into the cell. And this happens due to the action of the fast sodium channels. This is good. But these fast sodium channels have one particular characteristic, and that is they are very, very rapidly inactivated. Okay? And this is why you see sudden upstroke and it stops somewhere and starts going down. Because these channels start being inactivated, which allows the other channels to function more and to take over. And this one particularly, this very short period is called phase 1. And the actions here are related mostly to the efflux of potassium into the outside of the cell. But as you can see, it's very brief and we did not get into the full repolarization, and that's why this stage is called partial repolarization. Good? All right. Now, if you remember before, when we discussed the smooth muscle and the cardiac muscle contraction, we said the most important factor in that is calcium. And to get contraction, you need to get calcium into the cell. So we need influx of calcium. And as I told you before, the most important channel responsible for the influx of calcium is L-type, which is voltage gated. And that's exactly what happens here. This partial repolarization just gets the membrane into a specific potential that's enough to open the calcium channel. All right? That's why we called it voltage gated. It depends on a specific potential, a specific voltage of the membrane, after which it could be open and it could start this process of influx of calcium into the cell. Now notice, why are we in a state of plateau? Why? Because as you can see here, I haven't shown that potassium channels are inactivated. So there is like a balance, okay? Something going in, something going out, which balance each other, and that's why you get a state of plateau, right? There is no significant change in membrane potential. Now, if you reflect that into the cardiac cycle, as we said, it represents the state of sustained cardiac contraction or ventricular contraction, which is important, because if it was very short, the cardiac contraction will be very short, and the emptying of blood will be less, and it would be ineffective. So that's why we need some sort of sustained contraction. But that could not happen forever, and because we need to get into another cycle. And that's why you start having this phase 3, in which you see the repolarization or the decline of the membrane potential back to the pristine one. And this happens particularly because of the potassium channel. Now, as you can see here, these calcium channels got inactivated once we reached some certain potential here. And these potassium channels are still open, which allows more efflux of potassium. Now, I'm showing this for simplicity as it's the same potassium channel. But in fact, that's not the case, because what happens here is governed by different kinds of potassium channels from what happens here. But let's show it just for simplicity that it's the same potassium movement from inside into the outside. And finally, the cell gets into the state of resting membrane potential, or phase 4, and that happens due to the activity of the sodium-potassium ATPase, which exchanges 3 sodiums for 2 potassiums on expense of ATP hydrolysis. Okay? Is that clear? All right. Yes, please. Okay. Now, the absolute refractory period, or refractory period in general, what does that mean? Refractory means what? The cell is unresponsive, which means you cannot have another action potential here, right? And just think about it. When does the cell become refractory or unresponsive to more action potential triggers? Exactly, during the action potential. And basically from here, the top of phase 0, until this, let's say the start of phase 3, the cell is absolutely refractory. Relative here, when it goes down, and particularly if it went into a hyperpolarization state. Okay? But let's talk mainly about refractory period without these divisions, that the cell is refractory or unresponsive to stimuli once it is during the action potential. Okay? That's important because we're going to discuss it in a bit. Now, that's one part of the equation, but the other thing we need to discuss here is the relation between these membrane potential changes into the ECG strength. So just see this. This is a particular ECG strength, and it relays down from these changes or phases of action potential change. Now, if you notice, it does not change. These waves happen in particular phases of the action potential. And that's why it's important to understand that during the resting membrane potential, or phase what? Phase 4. Okay? The P wave happens during phase 4. What does the P wave represent? Atrial and contraction. Let's say contraction. Okay? So the atrial contraction happens during phase 4. That means these action potential waves and the changes happen in the ventricles, okay, and happen after we relay the signal into the AV node from the SA node, okay? But it's important that the P wave always happens during phase 4. Now what happens next is that the cell gets into phase 0, right? This rapid upstroke and rapid depolarization due to the activity of the fast sodium channel. And this is represented in the ECG strip by the QRS complex. Okay? Afterwards, as we said, the cell will get into these successive stages of phase 1, 2, and 3. And these are mainly represented by the T wave. And as you can see, it happens particularly during phase 3. So P during phase 0, QRS during phase, P during phase 4, QRS during phase 0, and T mainly during phase 3. Please.
This membrane potential for which part of the heart?
Good. We will say it in a minute. Are you good now? If you understand these things, the actions of antiarrhythmic agents will be very, very easy for you. So please notice how these things happen, why these things happen, and how are they reflected on the ECG strip. Any questions? All right. So the next thing is what your colleague asked about. This is the ordinary or the generic form of the cardiac action potential. Whenever you study cardiac action potential, they show you this picture, right? But it's actually not representative of the whole electrical conduction system within the heart. Because this action potential strip represents only atria and ventricles. Okay? And this is particularly easy to understand because it has this phase 2, right? Which represents the sustained contraction. So it should be represented here in the atria and ventricles. But the thing is, the action potential curves are totally different in the SA and AV nodes, as you can see here. And if I want to just show some differences, let's forget about the differences in the action in the membrane potentials, the starting and the maximum one. But I'm going to show you just one difference in the fact that it has a phase 0, phase 3, and phase 4. Phases 1 and 2 are almost not there, although you might see it labeled on some cases. But there is another important difference. Can you see it here? Okay. Yes. Exactly. Stop talking. So, as you can see, the biggest difference between these two is the difference in the slope of phase 0. As you can see here, it's a sharp upstroke, okay? While here, phase 0 just goes more and more gradually. What does that mean? And why does that happen? Why is this very sharp while this is gradual? Okay, so I will say one thing, and let's say it in very simple ways. People will give you more details, but I would say there's no activity of fast sodium channels in the SA and AV nodes. And that's why you see this difference being sharp upstroke while gradual increase in membrane potential in the atria and ventricles. Remember this fact because we're going to go across this in a minute, please. Exactly. Now, does sodium act during phase 0? Yes, in the atria and ventricles. But mostly the depolarization and the increase in the membrane potential is due to the activity of calcium channel. Okay? But let's just say it in a very simple fact. SA and fast sodium channel. All right. All these are basics, and they are important to understand the next topic related to the antiarrhythmic agents. Now, again, here's a summary. The SA node fires, and it has one major characteristic being what? The pacemaker. And this is represented in physiological books as the automaticity of the heart. Okay? Which means it can, what does that mean? What does automaticity mean? Exactly. The cell just spontaneously goes from phase 4 into phase 0. While in the atria and ventricles, you need some sort of a stimulus. This stimulus comes from the AV node and the Purkinje fibers and all these things. Now, if I want to say what's the major characteristic of the AV node? Exactly. It's the delay of the signal. Okay? There is the convergence of the signal, but most importantly, it's the delay of the signal, and it's about 0.1 to 0.2, okay? I forget, millisecond. And this allows the atria to fully empty and get the blood into the ventricles. And finally, if we want to have a major characteristic of these branches and bundles and Purkinje fibers, it's just a simple electrical conduction. So the major effects happen mostly in the SA node and AV node. In the Purkinje fibers and the branches, it's just the electrical conduction of the signal. Now, to understand a disease, you have to understand the normal, the physiology. So if I ask you, how does arrhythmia happen? Would that be easy for you? Yes, indeed. Why? Just look at this figure and give me the reasons why the heart could get into a dysarrhythmic break. So as you can see, I just laid it here. I just showed you the major characteristics of each part. So there's the automaticity, and this could be the problem. There's the delay, and this could be the problem. And there's the electrical conduction, and this could be the problem. Listen, memorizing is not good. You will forget in just a few months, and as long as you do not use this information. Always think in pictures. Lay down the information in a picture, and then you will understand things, and it's going to be much easier. Do not memorize. Because if you read the pathophysiology of arrhythmia, you're going to go into headache. Okay? Just lay it in pictures, and things will be much easier. So the arrhythmia means there's a problem in automaticity, there's a problem in the delay, and there is a problem in the electrical conduction system, and or. Yes? Is what? Yes. So that's why when I just had a simple classification of arrhythmias, I put it in this way. There's a problem in automaticity. This problem in automaticity could be related to the rate, right? The rate of firing could be increased or decreased. If it's increased, what do we call it? Tachycardia. If it's decreased, bradycardia. What could be another problem in the automaticity? What your colleague said. It's the origin of the firing. It's supposed to be in the SA node, but it could actually happen in other sites in the heart. Now, that's why we have another type of arrhythmia related to the origin of the automaticity, and it could be nodal or extranodal or ectopic. Now, the AV node has the potential to have an automatic firing, but because it's not as active as that in the SA node always takes the focus. It's the pacemaker of the heart. But that does not mean that the AV node does not have the ability to automatically fire and get into a phase 0. And that's why in some cases, patients might have an automatic firing within the AV node. Okay? Now the problem, or this is easy to understand, but the problem is when you have an extranodal site of firing, and this actually happens a lot. You could have multiple foci of firing within the atria or within the ventricle, okay? Which means that these cells acquire the ability to open the the sodium and the calcium channels to a level that could get the cell into automatic and spontaneous depolarization, okay? And you will study these things more in your fourth year and the different types of arrhythmia. But I'm just laying the basic information and how does arrhythmias happen. Now, the problem could also be related to conduction, and this could be in two forms. It could be related to the rhythm of conduction, which means what? It could be regular or irregular. Now, if it's regular, you always hear the word sinus, okay? Sinus means what? It just happens regularly in a regular rhythm, but there is an extra problem somewhere in the automaticity or in the delay of the AV node. Or it could be irregular. And finally, the velocity of conduction could be increased or decreased, and this could be a source of cardiac arrhythmia. Okay? So this is just a simple classification of the pathophysiological origins of arrhythmias. And it's all related to the first figure I showed you, and it just gives you simple information about it. Any questions? Good. Okay. Now, when we studied the drug discovery and the drug development, we always had this question. If this is what happens if these are the causes of cardiac arrhythmias, what do you think are the possible targets for pharmacological treatment? Just think about it. We just studied how arrhythmias happen. How could you inhibit that or change that? Please. Go ahead. Yes? Say it again. Exactly. Targeting the ion channels. What else? Please. How do you target that? From what we said. How? What she said. Channels. Let's say ion channels. What else? Exactly. What we discussed before, the major function of the heart is regulated by the sympathetic and parasympathetic system. So if I don't want to get into the ion channel part, let's get into something more global and just modify the activity of the sympathetic or parasympathetic system. What else? Please. The blood pressure?
Body temperature.
Body temperature. Could be. Okay. What else? Please. That's what he said. Targeting the sympathetic system. Okay. So what I put here is the following. Here is the heart, and here are the different constituents of the electrical conduction system shown in the heart. But at the same time, we should show also the ion channels because they are the most important factors in the regulation of the phases of action potential. So if you want to target the action potential of the heart or the different parts of the heart, you just need to target the ion channel. And this is exactly what happens in the development of antiarrhythmic agents. By the way, this is how you study or how you develop drugs. You just go to the pathophysiology, you see what's going aberrant or abnormal, and you just target it, okay? So we have basically three major types of ion channels that we need to modify to get an inhibition of the origin of cardiac arrhythmia. And these are the sodium, potassium, and calcium, right? Now, this is how we got into the classification of antiarrhythmic agents, and this was done in 1970 by Vaughan Williams. Okay, it's still in use, although we have shortcomings and we have limitations of this classification, but wherever you go and wherever you study the antiarrhythmic agents, you hear about Vaughan Williams classification. And it's simple. Again, think in pictures. What he did is just look at the ion channel. He classified the drugs into class 1, which are drugs that block or inhibit the sodium channel. Class 3, let's jump, which are drugs that inhibit or block the potassium channel. And class 4, which inhibit the calcium channel. Now we have class 2. What's class 2? Class 2 is the one that's more global than these, which is the thing that blocks the beta adrenergic receptors on the heart, and these are what? Beta what? Beta 1 particularly, let's say. Beta 1 receptors within the heart, so they can target the whole system, because the beta function within the heart could affect the SA node, the AV node, and the electrical conduction system. So it's a more global effect on the electrical conduction within the heart. And finally, whenever you fail to classify something, you just call it what? Miscellaneous. Miscellaneous means what? These are drugs that have proven antiarrhythmic properties, but we simply do not understand how they achieve these functions. Okay? And that's group 5, or class 5. So, how am I going to ask you questions in the exam? Here's one example how the questions will be. Now let's start with class 1. And class 1, as we said, are drugs that could inhibit or block the sodium channel. My questions will be the following. If you have this action potential strip and the ECG strip, tell me what effect could class 1 or class 2 or class 3 have on these parts. And it's simple. Just go back to the basic mechanism. This blocks the sodium channels. So the effect will be maximum where? Phase 0. Exactly. So that's where you have most of the effect from class 1 antiarrhythmics. Just remember that. This is phase 0. It's a sudden and a sharp upstroke of membrane potential into a depolarization state. Now if you block that, what's going to happen? Just a more gradual pattern of increase in the membrane potential. Because we cannot block all the sodium channels, all the fast sodium channels, okay? You might block some of these. And in addition to that, we said that you might have fast sodium channels and have other kinds of sodium channels that could be active. And that's why the major effect of class 1 is just a gradual increase in phase 0 or depolarization state rather than the sudden upstroke. Okay, if that's the effect, what could be the basic targets of class 1 antiarrhythmics within the heart? What? Please. Exactly. Atria and ventricle. Right? Why? Because as I said, the SA and AV nodes do not have the activity or the function of the fast sodium channel. And that's why the major effects of class 1 are on the atria and ventricle. And that means also another thing. Whenever you have an arrhythmia, and you know exactly that this kind of arrhythmia does not originate or does not have any relation to the atria or ventricles, do not give class 1 antiarrhythmics. Okay? Here's an example of how we tie information together. We got the basic physiology, pathophysiology, into the pharmacology. This is how you study the thing. Okay? So, it's just a decrease in the slope of phase 0 and a gradual increase in depolarization instead of having that sudden upstroke. Now, what could be the changes in an ECG strip? This is the QRS, and we said that phase 0 is related to QRS. Then what should happen if you block? Exactly. So it's a widening of the QRS complex. All right? Are you following?
Yes.
So this is basically the easiest way to understand the antiarrhythmics. We said it's phase 0, then there's going to be a decrease in the slope, And in the ACD, if the QRS is synonymous with the phase 0, then what happens when you block these channels is just a widening of the QRS complex. Okay, so here's the summary. When you block the sodium channels within the heart, what's going to happen is slowing of the depolarization and thus the conduction, increased slope of phase 0, and finally widening of the QRS complex. This is basic. Now, some books will call this class of antiarrhythmics as membrane stabilizing agents. Why do you think that's the case? From the mechanism we discussed. No, not really. It does not keep the cell in the resting membrane potential. It actually goes into depolarization, but in a rather more gradual fashion. What about the excitogenicity of the cell? Excitogenicity means what? How fast the cell could be excited, right? And if we represent the excitogenicity of the cell in phase 0, which is the increase in the membrane potential and depolarization, then if you block the sodium channel, you are decreasing the excitogenicity of the cell, right? Which means the cell is less excitable and it takes longer time to get into the depolarization phase. Good? Now, some other pharmacological fantasies people discuss, and it's actually how they classify the class 1 drugs according to the degree of blockade of the sodium channels. They divide them into 3 classes. We have the class 1A, we have the class 1B, which means that these drugs can block the sodium channel in a much weaker fashion than the class 1A, and we have the class 1C. Okay? So this is your comparison point. This is a moderate blockade. The one that has more blockade, a stronger blockade, are called 1C. I'm not going to ask you these questions, but just for you. Because I know you like to study more. And you have 1B, which has a weaker degree of blockade of the sodium channels. Okay? Now, the final thing I'm going to say about this class, which is a practical comment. In the past, class 1 agents were used frequently, particularly in the emergency department. Okay? And there's a drug called lidocaine. Okay? And lidocaine was particularly very important in aborting sudden or acute arrhythmias in the ER. Okay? We used to infuse it like this. Nowadays, these class 1 antiarrhythmics are declining, and we're not using them anymore, or I won't say anymore, but are less frequently used in the ER. That's because of their complications and unexpected outcomes within the heart. Okay? So that's why I'm not going to discuss too many of these drugs, and I'm going to move into class 2. Okay? Now, we said class 2 are what? Beta blockers. And if we just go back into the basics we discussed last term, we said that beta blockers inhibit particularly the beta 1 receptor within the heart, and they could have negative inotropy, which means what? Contractility of the heart. Dromotropy, which means conduction of the heart, and this is particularly done when it affects the AV node. And finally, chronotropy, which is the heart rate, okay? And this is particularly the effect of the beta 1 blockers on the SA node, okay? And that's how beta blockers could be used as antiarrhythmics. So they are like modifiers of the whole system. They don't modify one particular part within the heart, but the whole system. And this is particularly important in one case, and that is the heart, we consider them the heart rate controlling antiarrhythmic agents. Now, as I said before, we have the tachyarrhythmias, which means tachycardia, which could originate in different parts of the heart. Whenever you have tachyarrhythmia, your first line antiarrhythmic agent should be what? The beta blockers, particularly the selective beta 1 blockers. And there is another use, and this is important for you also in practice. Whenever you have MI, post-MI, there is one frequent and very severe and life-threatening complication, and it's called ventricular tachycardia. Okay? Ventricular tachycardia happens in patients after MI for different reasons. The first-line treatment for these patients is beta blockers. Okay? So whenever you get these indications in arrhythmia, always think about beta blockers. All right. Now, class 3, and we said are the drugs that will target what? Potassium channel. If we go back to the action potential figure, what could be the effect of class 3 antiarrhythmic? We said potassium channel is active through what? Through actually everywhere, starting from phase 1, 2, and 3. But most importantly is phase 3. Because as we said, here is a partial repolarization, and the plateau phase is going to be balanced with the calcium influx, but this is mostly related to the outward movement of potassium outside the cell. So if you block potassium channels, the major effect would be where? At phase 3. And this is what happens. If you block potassium channels, phase 3 would take a much longer time, right? And it would not fall as steeply as it was previously. Okay? This is the major effect of class 3. What about the ACG strip? The major effect will be where? In the T wave. So what's going to happen? Exactly. So if you prolong this and make it take a longer time, then what's going to happen is the following, which is the fact that the T wave will take a longer time to happen, and there is something called the QT interval in the ECG, which is important. And what happens is a prolongation of the QT interval. Good? All right. So here's a summary for you. There is a slowing of repolarization, prolongation of phases 2 and 3, which means there's an increase in the effective refractory period, what you asked previously, right? If you prolong phase 3, the cell will be refractory to more stimuli, so that means it does not get into a new action potential. And finally, there is a QT interval prolongation. Now, I'm going to discuss one representative drug of this class, and it's amiodarone. And that's because of one thing. Amiodarone, take it and write it, is the most commonly used antiarrhythmic drug in practice. Amiodarone is the most commonly used drug in practice. And you will see why. So it's a class 3, which means it blocks potassium. Here's some information for you. It's an iodine-containing thyroxine analog. And it was actually discovered by chance. Someone was working on a material, and that material, he used it, and it just relieved some sort of arrhythmias. And when they looked at the structure of that drug, they further developed it into amiodarone. So it was not some genius. It was just by chance. Okay? Now, interestingly, it has some iodine and thyroxine analog functions. The interesting thing is that amiodarone has the functions and the pharmacological effects of all classes of antiarrhythmic drugs. So it could target the sodium channel, it could target the AB nodal conduction, and it could target the calcium channel. And that was interesting, and it shows you the limitation of the classification we have right now. Amiodarone does not belong only to class 3, it could belong to any of the 4 or 5 classes, but because the major effect is on potassium channels, it was subclassified into class 3. Now, as I said, it has anti-anginal and anti-arrhythmic effects, and that's how they discovered it, actually. It was a patient who had angina pectoris and had some sort of arrhythmias, and he used it, and all of a sudden, his condition improved. that's the case? It's a fair question, and it's a common side effect of amiodarone, as we're going to discuss in a minute. And the problem is that thyroxine, whether increased or decreased, it affects the heart rate and the electrical conduction within the heart. But because the major effect is on the potassium channel, it's frequently used, right? But it's a fair question. Now, amiodarone could be given orally or by injections, but importantly, amiodarone has a very long half-life, which might last for weeks. Now, do you remember something we discussed before? A drug that has a very long half-life, exactly. So, as I said before, if a drug has a very long half-life and you want to use it in your patients, what should you start with? Loading dose, right? You load the patient by IV infusion, get to the steady state concentration, and then you convert them into the oral form. And this means one particular practical thing, which is never, ever start amiodarone at home. Okay? The clinical effect might take up to 6 weeks to take place. To notice any difference, it might take up to 6 weeks, unless you have the loading dose. But actually, in a very recent study, they found that even if you give the loading dose, the clinical effect will take 2 to 4 weeks. So it's not that great. But as you can see, it's hard to get these clinical effects. Now, could you understand why? Give me just one reason. Why does that happen? Why do we need to wait for 6 weeks to get a clinical effect? No. To 6 weeks, no. Please. Yeah, you.
Because the heart, the receptors in the heart will just like fight the drug.
6 weeks is a very long time. It's actually related to the fact that this drug concentrates within adipose tissue, and then it starts going into the bloodstream. Okay, so whenever you inject it or give it by oral form, it just goes into the adipose tissue and starts going up gradually, and that's why it takes a very long time to get a clinical effect. All right, the side effects are easily predicted according to what we said before. If it's a thyroxine analog, what could be a major side effect of amiodarone? What? Let's leave it for a minute. What else? Exactly, hyperthyroidism. But it could happen in both clinical forms. Hypo or hyperthyroidism are very common side effects for amiodarone. What else? He said arrhythmias, and this is exactly true. Amiodarone is considered a pro-arrhythmic drug as much as it's an anti-arrhythmic drug. Pro-arrhythmic drug means what? It could generate or lead to arrhythmias in patients. So you have to take care of that thing. The other things are nausea, and this is something I wanted to show you particularly, which is interstitial pulmonary fibrosis. Because this is a very serious and fatal effect of amiodarone, and it could be irreversible. Here is a normal CAT scan of the lung, and you could see how these things get into interstitial fibrosis, which means the patient could die. And actually, almost 10 to 20% of patients taking amiodarone, particularly the high doses of amiodarone, get this side effect, and 10% of these will die. Okay? So you have to take care of that. And finally, another thing which is related to the metabolism of amiodarone, it could lead to liver toxicity, but it's mild, and it could be reversible once you discontinue the drug. And neuropathy. So, whenever I want to start amiodarone, I have to admit the patient, I have to give the loading dose, and wait for some time to convert them into oral tabs, and then I can discharge it. But before even starting the drug, you have to do something called the baseline investigation, and these are what? Related to the side effects. You have to have a chest x-ray, you have to have a pulmonary function test, right? Because it has this side effect on the pulmonary fibrosis part. Thyroid function test, and finally, liver function test. Okay? These are important before you start amiodarone for your patient. Now, class 4 are the calcium channel blockers. And as we discussed before, we have two classes of calcium channel blockers, and these are the dihydropyridines and non-dihydropyridines. When does this lecture end? خلصت? Okay. We will stop here. We're going to have the antihypertension, I guess, next week. So we will take the first 10 minutes to discuss the rest of the lecture. And by the way, if you have any questions, just bring it next lecture. Okay? Thanks.